Hello, everyone. Good afternoon, and I'm excited to get started with our presentation. I'm Marianne Jackson, a professor of pediatrics and dean of the UMKC School of Medicine, and welcome to our 8th annual Quality and Patient Safety Day, featuring an amazing keynote speaker, an update from the UMKC QIPS Consortium, and oral and poster presentations reflecting contributions from 57 of our best and brightest learners and mentors. I want to pause for a second and just say it was just a little over a year ago when our students were forced to abruptly pause in their clinical rotations. We had to figure out how to navigate the care of COVID-19 patients with limited PPE, initially limited capacity for testing, and really unclear clinical guidance as to the best treatments. We have come a long way since, and we've made remarkable strides in all of these areas. At this point, cases, hospitalizations, deaths, and test positivity have all fallen. And with more than 50% of our adults vaccinated and the opening of vaccine eligibility to those 12 and older, we've gone from hope to optimism to reality that we're going to get back to normal, where we can be in person, and that in-person connection we all crave. We salute the CDC and their new recommendations that those who are fully vaccinated can be in person without masks, both indoors and outdoors. But we realize that there may be more to come in the months ahead. During the pandemic, we learned more about Zoom meetings than we ever thought possible, and we held tightly here to our educational, patient safety, and research missions to ensure that we did not lose momentum. The key themes that I saw personally were a continued laser focus on our goals around patient needs within the healthcare environment and within our community. And really, we saw our students, staff, and faculty demonstrate resilience and adaptability. I'm proud to say that we've been successful in our efforts to prioritize our goals in quality improvement and patient safety. And much of the credit goes to the strong leadership of our endowed Vijay Babu Rayudu Chair for Patient Safety, Dr. Mamta Reddy, Sari Cantrell, and to each of our clinical partners, including those who are leaders within the QIPS Consortium. So next slide. I want to share the agenda with you for today and also welcome the Rayudu family. We are very proud to have you here with us today to continue the legacy of Vijay as we improve care for all of our patients. So you can see the outline here. If you go back there one more time, Dr. Reddy, we'll be starting with our keynote speaker in just a few minutes. We'll be having our update, oral platform presentations, poster recognition, and then an advisory committee meeting before we have our virtual poster showcase. Next slide. So this slide shows the impressive success of our programs with this year, the greatest number of abstract submissions since the initiation of our program in 2015. Among the 57 abstracts, we see contributions from over 220 individual contributors, reflecting engagement by students, residents, fellows, faculty and other staff, mentors, and judges. You can also see participation from those reflecting more than 10 clinical departments, including emergency medicine, family medicine, internal medicine, OBGYN, pediatrics, psychiatry and neurosciences, and surgery. I'm looking forward to the program, and we're glad you're with us. And now it is my pleasure to introduce Dr. Jennifer Myers, an academic hospitalist, associate professor, and director of the Center for Healthcare Improvement and Health Safety at the Perelman School of Medicine, University of Pennsylvania. Dr. Myers received her MD degree from Hahnemann University School of Medicine and completed residency in internal medicine at Johns Hopkins Hospital. She is a nationally recognized authority on the importance of the integration between GME and healthcare systems. She's also on the editorial board of MD Edge, which many of us look at every day. Welcome to UMKC, Dr. Myers, and we look forward to your presentation.
Well, thank you so much, Dean Jackson and Dr. Reddy for this kind introduction. I wish I could be there with you in person, but please know that I'm there in spirit. I'm going to share my screen now. The title of my talk is Crossing the Quality and Safety Educational Chasm, and this is where I've spent almost my entire career, trying to bridge the health system quality and safety imperatives with those of the continuum of medical education. These are my disclosures, and these are our learning objectives for the hour. I'm going to describe the history of the quality and safety movement and its iterative influence on the field of medical education. We're going to consider the perspectives of academic clinicians relating to quality. And then finally, we're going to end up on a very timely topic, I hope you'd agree, by discussing health and healthcare equity, which I believe is the cornerstone of quality. I'd like to start with this quote by Maya Angelou. You can't really know where you are going until you know where you've been. And that is so true in quality and safety education. So we all, I think, are very familiar with the Institute of Medicine, now National Academy of Medicine's landmark reports at the turn of the century. And these reports let us know that the healthcare delivery system has several goals for high quality care. Care that's safe, timely, effective, efficient, equitable, and patient-centered. But turn the clock back and remember, in 2000 and 2001, what the public heard and what our profession of medicine heard is that, you know what? Oftentimes our care, our healthcare delivery system is not these things. And that had a profound influence with many ripple effects. At the same time that those reports were coming out at the governmental level, medical education was also undergoing a parallel reform, which was influenced very directly by what we were learning about quality and safety in the complex healthcare system. So together, the Accreditation Council for Graduate Medical Education, which accredits all of our students and residents, and the American Board of Medical Specialties, which oversees all of our subspecialty board certifications, came together and agreed upon 6 core competencies that all graduating residents should have before they go out into practice, and that we as faculty should continue to foster and develop throughout our careers. And I suspect many people on this call are familiar with those competencies, and the first 2 tend to be specific to the subspecialty that you're in, whether it's anesthesia or surgery or medicine. But the latter 4 in yellow here are what we call the cross-cutting competencies. And professionalism and interpersonal and communication skills, I think while they're no less important than any of the other ones, are pretty easily understandable at face value. But 5 and 6, systems-based practice and practice-based learning and improvement are not. And actually, they really were not well understood in 2001 when they were introduced. And there was a lot going on at that time. The field was distracted with impending duty hour reform, the effects of the Balanced Budget Act on Medicare funds for GME, as well as tort reform. So I wanted to just take a step back and make sure all of us understood the true goals of these competencies. I love this analogy put forth in academic medicine by Ziegelstein and Feibach early in the field. And he compares practice-based learning and improvement and systems-based practice to the mirror in the village. So let's talk through that a little bit, right? Imagine putting a mirror to yourself and your practice and that data, and identifying areas where you're doing really well, but then identifying areas where you're not, where you've identified a performance gap, and you're committing to trying to understand why there's that gap and what you can do as an individual physician to close it. On the other side, the village is systems-based practice, which is much more macro level. it's outward looking, right? And our competency here is that we recognize that we're part of this complex system, but that there are things that we can do or not do that can influence the outcome of a patient, and actually engaging with the system to improve the delivery of care to either an individual patient or a larger population of patients is part of our role as a physician. So at the same time that the core competencies came out, the concept of competency-based education was new to our field of education. So previously, we always started with a curriculum around a topic of importance. But as the national landscape was changing and the American public was looking to the accreditors to hold us accountable, we had to look outside and look at our health needs and our health system needs and say, are they telling us something that could inform the competencies that we then need to work backwards? And I think this very much is relevant to those systems-based practice and practice-based learning and improvement competencies. So if we go back to our timeline here, I just want to emphasize that we must remember as we go through this that there was a lot of changes to the reimbursement and payment systems over the last 2 decades. Some of you may remember initially, it was just pay for reporting. So hospitals had to share their data on a few specific conditions in order to receive a certain percentage of Medicare funding. And now, as we know, it's pay for performance, whether it's a process metric or an outcome metric. And it's not only Medicare and Medicaid, but it's our private insurers that are also adopting these carrots to get to higher quality care. Well, I think if we can refer to the first decade as childhood, I would say the next decade is adolescence. As a mom of 3 teenage boys, we know this is a tumultuous time, lots happening, and a lot happened in the field of quality and safety education over this last decade. And what I want to take you through now is really the evidence imperatives that we must do a better job of teaching and inculcating this work. So we'll start with safety. Several years after the report To Err is Human, Chris Landrigan and colleagues looked at rates of medical error in 10 North Carolina hospitals and found that over a 5-year period, the rate of preventable harms did not improve. And this was based on physician judges who were both inside and outside of the study institutions. A few years later, Wang and colleagues looked at trends in adverse events related to 4 common hospital conditions. And they looked at data from Medicare patient safety monitoring systems and found that in 2 of these 4 conditions, there was no improvement seen. Then there was this landmark study in the field by David Ash and colleagues at Penn and JAMA, who were the first to compare residency programs based on patient outcomes by asking whether OB/GYN residency programs could be evaluated by the quality of care that their alumni deliver. And they looked at 9 measures of maternal complications for both cesarean and vaginal births and found that women who were treated by obstetricians who trained in residency programs with higher rates of risk standardized maternal complications had an adjusted complication rate 1/3 higher than women treated by obstetricians who trained in programs that had lower maternal rates. And very interestingly, these rankings didn't change when adjusted for the individual physician licensing examination scores. A few years later, also from Penn, Neha Bansal and Rachel Kells used those same research methods in the field of general surgery and found a similar trend. Another thing that was very much in the news and in the literature in 2014-15 was the concept of high value care, cost-conscious care. Candace Chen and colleagues had this important study in JAMA Internal Medicine, which found that general internists and family physicians who completed residency training between 1992 and 2010, and they found that the spending patterns in the region in which their residency program was located was associated with expenditures for the care that they delivered in practice to Medicare beneficiaries. And this really raised the possibility that interventions during residency training might have the potential to control future healthcare training. That same year, Brenda Saravich and colleagues at the ABIM found that regardless of overall medical knowledge, internists who trained at programs in hospital referral regions with lower intensity medical practices were more likely to recognize when conservative management was appropriate as opposed to aggressive management. And this was determined based on a subset of questions on the certification exam. So just really thought-provoking. You know, and these last couple studies that I've shown you really underscore this imprinting of the apprenticeship graduate medical education years onto this long tail, right, of clinical practice. And this and other evidence led Congress to commission this report from the Institute of Medicine, now NAM, which was titled Resident Duty Hours, Enhancing Sleep Supervision and Safety. And this did result in the subsequent duty hours, or the current duty hours that we know of. But a full half of the report was related to inculcating residents and fellows and really all learners into safety and quality and making that part of their training and their thinking. That led to the next GME accreditation system, which had two important parts. The first was milestones for residency training, which again was born out of this competency-based approach. And the second was something called the Clinical Learning Environment Review Program, where I've spent a lot of my time. So this was the first time where an accreditation body was saying, you know, the hospital and its executives and administration, you have to partner with graduate medical education and vice versa, because we know that this learning environment that they're training in matters. So this was very profound on the field and had a lot of ripple effects. Now you may be wondering, I've been very GME centric so far in my comments. So let's talk about the other parts of the continuum. The American Board of Medical Specialties and CME. So just when those core competencies came out, the maintenance of certification program was released. And remember, part 4 was the tough part, to be honest, for all physicians. This is practice assessment and improvement. It's that mirror component of practice-based learning and improvement. So that was new. And then in the next decade, the ABMS came up with a very novel program called the QI Portfolio Program, which over 50 academic medical centers participate in which actually the healthcare system can look at teams of individuals that are doing improvement work in the system and decide or grant them MOC Part 4 credit if it reaches a particular quality level. So it reduces the friction for the individual physician that's trying to get credit and makes it more a natural part of their work. Last, but definitely not least, what about undergraduate medical education? So I just want us to take a step back and make this one point. You know, the reason why the initial changes in the field were in GME and CME is because while education across the continuum changes the individual, right? Changes our knowledge, skills, and hopefully our attitudes. When it comes to physicians performing in their current environment and making changes to practice, you got to hit the sharp end, right? Who's delivering the care? Who's making the orders and making the decisions? And CME clearly is there. And, you know, I think, again, based on the mounting evidence we have and just what we know from resident and fellow practice, we need to be starting there. And I don't mean to make undergraduate medical education any less important, just to kind of explain why we started where we did. But let's talk about UME, because important things did happen in the last decade that I want us all to reflect on. The AAMC partnered with many institutions across the country to create something called Core Entrustable Professional Activities, for entering residency. That's a mouthful, but an EPA is an observable professional activity that requires the integration of several competencies. And 4 of the 13 you'll see over here on the left directly relate to quality and safety, in particular EPA 13, which is saying that upon graduation from medical school, a student and entering intern should be able to identify a system failure and contribute to a culture of safety and improvement. Another big change during this decade happened at the level of the USMLE. I had the distinct honor of serving as one of the co-chairs for the Patient Safety Text Development Task Force, and we worked on revising the social sciences section of this outline. And now on section 2 and 3, or part 2 and 3 of the USMLE, there is expanded content in this area. And we know that students tend to study and pay attention to what's on the test. All right, also in this decade, a very new and important framework came forth called health system science. I think we've long known about the 2 pillars of medical education: basic science interwoven with clinical science. What Jed Gonzalo and others promulgated was, well, what if we thought about health system science as a 3rd pillar? Not something added on, but something integrated and connected from the start. And that led to a lot of great work, which is endorsed by the American Medical Association. And over here on the right, I grabbed this photo. I like it because it shows the patient at the tip of the iceberg, and then all of these fields and things that have cropped up over the last decade, you know, kind of like popcorn. And what health system science does is really bring them together and say, you know, they're all interconnected. And it can help educators from a conceptual perspective. So that's the whirlwind tour. I think we're in young adulthood, which is always exciting. And so it'll be very interesting as we all watch together how the field evolves. So I want to switch gears a little bit and take you on a little bit of a journey and ask you to consider the perspectives of academic clinicians related to quality. And I want you to just reflect, you know, imagine you're with your peers in a coffee shop, or we're all together in grand rounds, and, you know, you're wondering what the person next to you is thinking. And let's be a little skeptical and think about, why might academic clinicians be skeptical about quality? I love this cartoon. It has the middle schoolers outside of the principal's office. 2 of them said some bad words, and the 3rd of them said QI, which I guess is a bad word. And I felt like this, I will say, early on in my career when I was trying to forge ahead with this. But there are a lot of things, and your reaction to these may vary, depend on where you are, what the culture is like. But I want to unpack them for you to talk about where I think some of the skepticism or questions come up. The first is new terminology. There's a lot of QI gurus out there who really love their methodology. And there are several methodologies in QI. One is lean, which comes from Japanese and comes from Japan and uses many Japanese terms like kaizen or going to the gemba. Another very common methodology is Six Sigma, which, you know, comes from industrial origins, Motorola actually, and you can see this reflected in a bit of the language. And then the third, which may be more familiar to some of you, is something called the Model for Improvement, which is based around plan, do, check, act cycles. But what I want to emphasize here is that regardless of what you are using in your institution, the core components of quality are the same. It's structured problem solving based on the scientific method and includes all of these bullets here. And, you know, we might do better by not being maybe as zealous about our particular method, particularly when we're teaching or introducing it to new people. Is QI and clinical care so different? I think this depends on your perspective. My colleague Ryan Buckley and I have thought a lot about this, and particularly how to teach it to medical students. And just bear with me for a second while I go through this analogy with you. You know, when you approach a systems problem in any of the methodologies, the first step is to use empathy and go out and talk to the people that do the work. We call this voice of the customer questioning or contextual inquiry. Well, you know, when we take care of a patient in the hospital or in the clinic, what do we start with? We start with that history subjectively and active listening. If we go back to our systems problem, our next step is to go to where the work is done and we map out the process. We get data. Similarly, when we care for a patient, we do a focused exam and get some data. And then we get labs and imaging data to inform where to go next. And then finally, the cornerstone of quality is making a change and seeing whether it results in improvement or not and iterating upon it. And in clinical care, right, we walk out of that room and we come up with a first line plan. And then we follow to see if that works and see if we need to iterate or reassess our differential diagnosis. So just a little bit of food for thought about how we think about those two things. The other thing I wanted to talk to you guys a little bit about is quality assurance and the difference between quality assurance and quality improvement. And people, and if you're not sure the difference, don't worry. Many people don't know the difference, but I want to walk you through the differences because it's important to how the field is perceived. So quality assurance is an older term. And imagine you're looking at the surgical site infections of 40 or 50 surgeons at your hospital, and they fall along this bell-shaped curve here. A quality improvement approach would say, let's look at who's not doing well, those 4 or 5 people, and figure out how to get them better. And, you know, hopefully you wouldn't, you know, get rid of them completely as this cartoon looks like, but that's the approach. And honestly, the way some quality data is sometimes presented in medical centers, it can feel like this. So how is quality improvement different? Well, it's different in a very important way. The focus in quality improvement is, let's look at that bell-shaped curve and let's look at who's doing well. What are they doing that's working well? And how do we take that and spread the learnings and make everyone better? And so you can imagine, particularly for clinicians that were used to quality assurance or were still hearing about quality with those underpinnings, it didn't go down so well. Now let's talk a little bit about the academic potential. I think we would agree that there are 3 very traditional physician careers in academia, right? We know the phenotype of our basic scientist, our clinical investigator, our clinician educator. And actually the metrics of success aren't that different from my institution compared to your institution. They're publications, they're grants, they're teaching evaluations, and eventually they get all rolled up into a promotion of some sort. But what about the clinical quality improver? And so now in 2021, we have a lot more tools for the clinical quality improver, but are we using all of them? And are we maximizing the potential for these individuals to fit into our academic culture? And I would submit to you that we have to make them fit in. Let's talk about some of those tools that we have for these academic clinical quality improvers. The Squire guidelines, which were developed by Greg Ogrink at Dartmouth and colleagues. This stands for Standardized Quality Improvement Reporting Excellence in QI. And essentially this is a outline for people who want to publish their improvement work. So just like the Consort guidelines are used for RCTs or the PRISM guidelines are used for meta-analyses, journals now are looking to these guidelines, and this really elevated the field and produced higher quality, more generalizable work in our peer-reviewed literature. You know, I think the same thing over the past decade is more and more institutional review boards have specific guidance for trainees, faculty, staff who want to disseminate their quality work. Here I'm showing you 2 screenshots. One is from Penn Medicine, our adult healthcare system. The other is from the Children's Hospital of Philadelphia, our children's hospital. And both groups, we've developed with them guidance to help faculty and others understand the difference and navigate the pathway in a safe and protected manner. There's been a plethora of journals focused on quality. These are just a few of them. And honestly, what I tell my learners and faculty is that if you've done work that you want to generalize in quality and safety, think about the quality journals, but also think about your most clinically focused journal or two. And I can guarantee you in that journal, there's going to be a column or a section for quality. And I'm just showing you a few here as an example. They tend to call the columns different things, but if you look, you'll find it. So real opportunities for faculty to move forward. And quality and safety work is increasingly recognized in promotion criteria. This is from our faculty life and professional development webpage at Penn, and the wording in our academic clinician track actually says that the major emphasis of this track are clinical care, quality and safety, and education, including leadership in these domains. And it's not just at Penn that we're doing this. This was a nice paper by authors from UCSF, University of Toronto, and University of Washington, where they also were seeing this type of language in their promotion criteria. So, you know, with all of these tools, you might say, well, how do we promote these careers locally? How do we get more of these people? And I'll be a little provocative and say, how do we promote careers in cardiology or nephrology or infectious disease? And you know, what I'll say is you give people experiences and you get them interested. And I know that you've done a lot of that at UKMC. So you can imagine you have experiences in medical school related to the heart. People get interested. They go into internal medicine residency. They have more experiences. They're even more interested. They become fellows, and then voila, there they are. So the career ladder for quality, I'd submit to you, isn't any different. How do we build meaningful experiences for students who are interested in the healthcare delivery system and figuring out how they can be a part of it, and having appropriately different experiences, more advanced experiences for residents. In terms of specialized training for quality and safety, there's about 15 master's programs nationally. We have one of them, but you do not necessarily need a master's in healthcare quality and safety to do this work, but you probably do need some additional training, and there are many certificate programs across the country in this space. But you can see by building this ladder, you're going to get professionals like this. And what I love about the field of quality is how equitable and welcoming it is. We need these people in all specialties. So I'm going to end this part by talking about the perspective of quality and safety education as being something that's hard to teach. And do our students and residents and even our faculty, is this part of their identity? I felt like this, and if we have any quality and safety educators on the line, you can relate to it. Here's just some of the questions: what to teach, how to teach, who will teach, with what time, and finally, will the learners buy in? And the buy-in is important. If this education becomes a checkbox, it's not going to be impactful. I think we all know that. I love the titles of these articles. I think, you know, a screenshot is worth 1,000 words. The first reflects on undergraduate medical education, health system science, the broccoli of undergraduate medical education. So we all know about broccoli. We know it's good for us, but it doesn't taste very good going down, particularly when you're a child. And Jed Gonzalo and Greg Ogren just really write about the reality of this as you're trying to fit it in to medical school education and reach the students. This second research report from academic medicine, Jury Butler and colleagues looked at graduate medical education. And I love this. This was one of their qualitative quotes from the residents. It feels like a lot of extra work. Resident attitudes about QI and implications for an effective learning healthcare system. And again, there's truisms here that we have to pay attention to. In another study, also out of Penn State, they looked at how physicians felt, or students felt, I'm sorry, after a longitudinal curriculum in health system science. And what they found was that it created tension for them in their professional identity. So in other words, some of the students felt that their professional identity was misaligned with what was being taught, and that they felt this tension existed not only for students, but for faculty. And negative faculty comments suggested to students that health system science was not important within the healthcare culture. There's a lot to learn there. We published this earlier this year, and the study was actually designed to look at two different ways of teaching quality to residents. But in our qualitative interviews, this theme came out loud and clear, which was that residents in both groups recognized that QI skills could be applied to their future career, but most of them did not view the work as part of their career. So very interesting to reflect on. And you know, if I think back to the first decade of the safety movement, I was a patient safety officer. You know, there were 2 or 3 people that were dipping their toes into this field. And you know, then the second decade, which I know you've seen as well as I, now we have vice chairs for quality and safety. We have chief quality and safety officers. There's more people, but it's far from the majority that recognize the importance. I'm not an expert on professional identity formation, but I thought, just given the topic, I'd pull this out for all of us to reflect upon and remember that as we become a physician, our personal and professional identities start to merge. And that's why I think I'm here today talking to you about this topic, since all of you have the potential to impact your learners. So we're going to end here with discussing health and healthcare equity. I'm taking you back to the timeline, and I skipped a few important things, but I want to come back to them now. Remember, in 2001, equity was one of the 6 aims for high quality healthcare. What you may not know was that in 2010, the IOM NAM commissioned a paper called Unequal Treatment. And this affirmed that achieving equity is essential to quality, actually said it's a cross-cutting domain. It shouldn't just be one domain. And then several years later, the Institute for Healthcare Improvement, otherwise known as the IHI, which is the leading national organization in the field, put forth this white paper called Achieving Health Equity, a guide for healthcare organizations, which was like a playbook for institutions to try to begin to do work in this field on the front lines. But if we were honest with ourselves, I think you'd agree with me that equity is the forgotten name, or has been the forgotten name of healthcare quality until very, very recently, right? Until this happened. I don't think I need to tell any of you about the racial disparities that the pandemic has shown us. And right, we know that this is not biologic. Race is not a biological category, it's a political category with biological consequences related to social inequities. And COVID just shone a big spotlight on that. Just to go through a bit of the literature here, we certainly knew about this previously. This was a landmark paper in 2014 by John Aanian and colleagues, which showed that Medicare enrollees between 2006 and 2011, that Black enrollees were substantially less likely than white enrollees to have adequate control of their blood pressure. So just to orient you on this graph, Blacks are in the dark blue, whites are in the light blue, and these are all of the regions. And what's striking is not just the disparity, but that it persists in every region except the West, which is interesting. And they didn't just look at blood pressure, they looked at LDL cholesterol. They looked at hemoglobin A1Cs, and they found the same thing. This year, in 2021, Matthew Best and colleagues published a paper in JAMA Surgery, which looked at whether national initiatives were associated with any uptake or improvement in the number of surgical procedures among Black patients versus white patients. They looked at 9 major common surgical procedures. I'm going to show you the results here of 3 of them: CABG, carotid endarterectomy, and total hip arthroplasty. And what you're seeing here with white patients in the dark gray and Black patients in the light gray is the rate per 100,000 of these surgeries. And the 3 graphs that I'm highlighting in red are urban teaching hospitals. And the 3 graphs on the right are non-teaching hospitals. So the disparities are large and present in both and across the nation. And this was adjusted. So it was adjusted for their insurance status. So regardless of whether they had Medicaid, Medicare, or private insurance. So, you know, here we are. And what I'll assert is that we must integrate health equity into our culture of continuous quality improvement. It's the only way we will be successful. Whatever you and I can do to show those around us that these are overlapping Venn diagrams, the better off we will be. All QI initiatives have one of 3 possible equity outcomes. And many of those good intentioned improvement projects widen disparities. If you look over here on the left, probably the things that you may have heard about: smoking cessation, obesity prevention, breast cancer mortality, tons of money poured into them, but they actually widen the disparity. And there's a few initiatives that reduce or eliminate. They're very, very structural, like literally changing the water or changing the salt. But in the vast majority of QI interventions, the disparities are sustained. And I'm as guilty of this as anyone. And that is, in all the improvement work that I used to do, I never looked. And so if we're not looking, we're not going to find. So we have to take the first step here, right? We have to tackle disparities, but where do you begin? Well, we know now about the Plan, Do, Study, Act cycle. We know quality improvement methods, and we just need to apply them to equity problems. Now, there are some nuances and some things that are relatively new for the healthcare QI community. The first is, when you're planning your project, you actually have to collect, analyze, and stratify your data by race and ethnicity and gender and language, or whatever you want to look at. And that requires resources and time. Then once you start to embark on figuring out what the root causes are, developing countermeasures, we as healthcare providers can't do this in a vacuum. We have to talk with our patients and or their families and communities. And this can range from some short interviews or focus groups in the hospital or exam rooms, all the way to more deep relationships with community organizations. What my colleague Jaya Sola and I found over the past year is that we had more and more faculty reaching out to us and QI staff really wanting to do this work in earnest. And but they didn't really know where to start. So we designed a 3-part workshop series for them to emphasize these concepts. They're going to be sharing their work with us in just a month, so we're very excited about that. And I did, just to close up, wanted to share with you some of the data from one of the 20 teams. This is a team that's working in our newborn nursery. And lo and behold, when they looked at the rates of exclusive breastfeeding in new moms, they found that Blacks were 80% less likely to leave the hospital committing to breastfeeding, whereas whites were at 93%. And so you can see, you have your SMART aim, you see the disparity gap. And this quote by Edwards Deming, who is the father of the Deming cycle, which is the PDSA cycle I love. And it says, without data, you're just another person with an opinion. And I think it's showing data like this, articulating the gap, one project at a time, one hospital at a time, is across the country is what we need. So in summary, hopefully I've helped you to see how medical education has been iteratively informed by health policy research and payment reform over the past 2 decades. I think academic medicine is evolving to embrace quality and safety, but I do think we still have some work to do. And then finally, achieving health equity and healthcare equity are integral to this work. So thank you very much for your time and attention, and I'd be happy to take any comments or questions.
Dr. Myers, that was a great presentation. Let me ask you, as you build infrastructure to bridge the gap, how important is it to create not only a large group of students, residents, and fellows who are engaged in this work, but in the past, this has never been a focus for faculty. So how do we raise up the faculty and get them engaged so that they can be the mentors moving forward?
Thank you for the question, Dean Jackson. I think faculty development and engagement always is the elephant in the room. So I have a few thoughts, and I think we're going to dive into this a little bit more deeply this afternoon. But my one thought, and you may have experienced this at UKMC, is that when you get students, residents, and fellows who are passionate about it and willing to put in some of that sweat equity to do the work, the faculty want to help them, and they want to make them successful. And so I definitely have noticed some spillover effects and newfound interest from faculty who, have a mentee and they want to do right by them. And so the trainees are really pushing the profession. So that's one way. I think the other way is we have to meet busy faculty where they are and offer professional development in more than one format. There's, not everybody is going to be going out to get a, 4-course certificate across the country or has the time to get an MHQS or an MBA. How do we be smart about delivering some just-in-time learning? I've seen many interesting educational models where there's co-teaching. So in other words, a QI expert teaches the trainees and the faculty mentor at the same time. And then the third way I would say is I do think, and I'd love to hear more thoughts from others about this, that we haven't been explicit enough with faculty that this is a viable career pathway, right? Improving the healthcare delivery system is just as important as leading a medical school clerkship or, leading a lab that, is developing a new molecule, or it's different, but it's just as important. And so that's why I was a little provocative there in some of my comments. And I do think faculty affairs and the way promotion tracks are written can help to draw in some of these people.
With that in mind, is there a pathway for medical students at Perelman School of Medicine to achieve a distinction in this area? And is that something you thought about?
It is something we have thought about and we are actively working on. My career really did start in GME and move out, but 100%. And I think even though we have not started it yet, we do support, our center supports 4 or 5 medical students every summer to work with fellows and faculty, and they find us and we find them. So we're looking forward to formalizing it.
Dr. Reddy, I'm going to turn it over to you.
All right, Dr. Myers, there are a couple of questions in the chat that I'd like to ask you.
Of course.
First off, are you able to share your presentation slides? Many people here would be interested.
Absolutely.
All right. And Dr. Clark has a question. Thank you for this wonderful talk. Many points hit home for me as a pediatric hospitalist who does a decent bit of coaching. When trying to engage trainees more deeply, does discussion of emerging payment models such as capitation help drive home the point of providing the right care at the right time in the right place for the right patient, as these learners will be working a decent bit of their career with these payment models? Any thoughts on payment models, Dr. Myers?
Yes, my first thought is that they're complex and ever changing. But what I found, particularly at the medical student, but also at the resident and fellow level, is that the knowledge of the payment models and just how healthcare is structured is very thin. Let's be honest with ourselves. We all learned this in practice as different things happened to our patients, and we needed to understand a bit of the business side of medicine. I have found that starting out with that is a hard sell. I think because it is all so new. That said, I think the further along learners get to being in independent practice, so talking about these things at the end of a third or a fourth year residency or the end of a fellowship, you often have a more engaged audience than when you're starting in medical school or even internship. So trying to find out where do you grab their attention. It's interesting. A related comment I'll make is that a lot of our residents that have gone through our training programs see how the QI concepts could be adapted to some of their future careers, but more in terms of using that method of problem solving, like in a lab or in business, as opposed to like in the healthcare delivery system. It's interesting.
Lots of comments, positive comments. Thanking you for the presentation. I'll let you review some of those, Dr. Myers, but I have a question. If you knew now what you knew then, what would that one thing be that you'd advise this group in this early part of this journey?
I think I would advise you to approach this as building an army. That's always how I've approached this work. And I have seen time and time again in student groups, regardless of specialty, regardless of year of practice, or even location across the country, as learners get involved, faculty come along, but you do need to have people like us, Dr. Reddy, and others on this call to make those bridging connections. But we really are, we're building a new community, right? The clinical quality improver, I just want to leave that in your mind. There are careers that we are making by these exposures that didn't exist 10 or 20 years ago. And so my advice would be to approach it as you're building an army. We're in it for the long haul, and have patience with yourself.
Thank you, Dr. Myers. Any other final question? All right, seeing none.
Well, I did want to ask one question, and I'm sorry I did miss part of Dr. Myers' presentation. As you were talking about a systems view in terms of this work, one of the things I didn't explicitly hear was a discussion about how the clinical practitioner deals with issues around social determinants of health that their patients are coming into the exam room with, and how do you address those as part of your comprehensive care for patients?
Thank you for that question. I actually had a slide or two on that, and I had to pull out because in the interest of time. You know, systems-based practice, that core competency, if you look at the words, it doesn't talk about social justice. It doesn't talk about social determinants of health or equity. Yet, to your point, there's such a large part of it for many of our patients. And there was just an opinion piece in academic medicine about the need to rewrite it or make sure there's subheadings, and you hit the nail on the head. I think how do you do that is that's a much broader question. I think when we're with learners, we're just trying to get them to think about that, right? And how those social determinants of health are impacting, whether a patient is showing up and how they're showing up and what's going on with adherence and disease progression. And then I think we need to draw on the expertise of our social workers, of our nurses, of our care coordinators. We can't solve those social determinants of health alone, but we can advocate for team-based models of care to help our patients outside the exam room.
Any other questions before we close? All right. Thank you for this outstanding presentation, Dr. Myers. So on target to address where we are here at UMKC. Thank you so much.
Thank you, everyone. Have a wonderful day.
And we'll move to the next portion. My name is Emily Hillman, and as chair of the Event Steering Committee, I'm honored to have the opportunity to moderate this 8th annual Quality and Patient Safety Day. Founded in 2014, the Quality and Patient Safety Consortium here at UMKC is comprised of 6 affiliate hospital programs and 4 university-based health science schools that serve the UMKC School of Medicine. You can see the list there of our hospital affiliates. The mission of our consortium is to lead in the scholarship and dissemination of local, regional, and national activities directed at enhancing the quality of care. The goals of the consortium, to summarize them, include to develop QIPS curricula to support future clinical practice, and also to develop an infrastructure to facilitate collaboration, communication, scholarship development, and sharing that will improve the quality and safety in our community. The consortium is chaired by Dr. Betty Dries, and is governed by representatives from affiliates and stakeholders from the community that work to bring their diverse expertise and perspectives to help us develop the consortium further, do the work we do, and offer to our community of learners what we have to give them across all of our hospital-based programs and our health science schools. What you see here is the white star. You see our steering committee members. And then with the green star, our advisory committee members. And then in yellow, please note that these are new members to our advisory committee over this past year. We'd like to thank everybody that is involved in the various committees for all the work they do on a daily basis. Next, I'm going to go ahead and introduce, I think you met her already, Dr. Mamta Reddy, who's the Vijay Babu Rayudu Endowed Chair for Patient Safety here at the School of Medicine. And she's going to share some updates about the work that the consortium has done over the past year.
All right. Thank you, Dr. Hillman, and thank you to everyone for being here today. I'd like to start this update with our aspirational vision. Our vision is to develop a quality improvement in patient safety leadership track to build future quality and safety leaders. As we heard from Dr. Myers, that appears to be a gap in our future across our healthcare system. So in our efforts to integrate this experience into the existing School of Medicine curriculum, we run into challenges in finding extra days and weeks to integrate such a track into an already accelerated curriculum. So we pivoted, and we plan to use instead a competitive application-based process to recruit a cohort of 12 students in each year who will enroll in either a 3-month bronze track, a 5-month silver track, or an 11-month gold track. This will include coursework at the Block School of Management, with the silver option specifically designed to serve our MD-only students. The experience will help participants set themselves apart from their peers through mentorship from quality and safety leaders across the affiliate programs, many who are here today, in order to teach operational problem-solving skills and deliver scholarly output. We'll be looking to employ the scientific method to elevate health equity, reduce variations in care and service, and improve care processes that add burden to healthcare workers across the health system. Upon graduation, the participant in this track will earn a commendation titled Distinction in Healthcare Quality and Patient Safety. And we'd really like to be able to provide scholarships for housing and tuition so that cost is not a barrier to participating. So our current effort is focused on seeking funding. In the meantime, we've had success piloting a quality improvement patient safety curriculum and content into School of Medicine coursework, beginning with year 3 students. This approach translates the steps for applying medical decision-making steps into parallel steps for solving an operational problem. And notice that both use the scientific method. And additional info about this can be found on our website. This has been an exciting year as we piloted matching coaching support with students interested in applying this methodology to project. And we have several coaches we wanted to thank who paired with these 3 students who will be featured in the platform presentation and also in our poster showcase. So we spent some time to build a self-sustaining tool for those interested in independent pursuit of a QIPS project. And a link to this can be found on our website as well. And this online quality improvement guide walks through some steps such as how to select an appropriate project for an improvement effort. It helps us learn about the A3 framework for problem solving, talks some about publishing QI work, highlights the activities of today's event, and provides a lot of resources, including articles and databases and books. And as one is using this guide on their own, they can seek other contacts and support, including our School of Medicine librarian. Fancy animation. Doing its own thing now. Okay. Last summer, we were asked to create a QIPS elective in case a student needed to quarantine in the middle of a rotation. And this could impact graduation timing for a year 5 or even a year 6 student. So depending on which week of the rotation the student needed to withdraw, we created independent coursework and self-study with some check-ins at specific project milestones to be able to help the project move along, and we hope that this will be something attractive to other students even beyond the pandemic. So despite the delays in getting the QIPS leadership track off the ground, we're still very excited about our next steps and the opportunities that it presents both for students and faculty. And one gap we've identified is that in order to provide this kind of individualized QIPS project coaching to students, we need to develop additional faculty members who are comfortable in this specific type of coaching. And so we've created a list of burning platform questions that we could be asking faculty and why they should get involved. And I have some updates to this based on Dr. Meyer's presentation, but we want faculty to see this work as a way to make their work count twice and maybe even thrice. So scholarly work can count for more than just scholarship by engaging in projects that reduce waste in their daily workflow, employing well-being by learning methods to lead change, being a part of a solution instead of just complaining about a problem. And leading a project can be a means to coach and develop others while providing an excuse to connect with their professional communities. Specifically this fall, we plan to launch faculty development sessions and a faculty scholars network with Dr. Christine Sullivan's support through the Office of Professional Development. And using the Student Research Society type approach for other interest groups, we plan to begin monthly meetings starting in the fall for students interested in QIPS-related extracurricular activities to provide them opportunities to learn from QIPS experts from the affiliate hospitals, and also to connect them with project coaching and support using the A3 framework for problem solving. If any learners are interested in hearing more before that becomes publicly available, please reach out to Sari and she can help connect you. So today we're excited to bring to you the 8th Annual Quality and Safety Day that honors the memory of Vijay, from whom UMKC remembers as a third-year medical student. Because of his untimely passing in 2007, this effort has become a way for his family to honor him in ways that continue to contribute to the field of medicine. So I want to take a quick moment to show my gratitude to the Rayudu family for making this work possible. In previous years, this event has been known to be a very lively, interactive event with a lot of social and academic content that's not particularly possible in our current climate. But in previous years, the program has featured highly esteemed speakers and guests who are now making national headlines in our current times as well. As Dean Jackson mentioned in her opening remarks, this year bears a record number of 57 abstract submissions, with a steady annual increase in not only the number of abstracts submitted, but also the quality of those abstracts, such that we might soon have to cap what we can accept, because what we could fit in the hallways of the 4th and 5th floors of the medical school. This year, we have representation from over 8 academic departments across the 5 affiliate hospital programs, representing different institutions. And we're so excited to be featuring today the top 2 abstracts from each of the 2 categories, the student category and also the resident and fellow category. So give us just a few minutes to make sure our presenters are all present, and Dr. Hillman will take over.
Everyone, I think, is here and ready to go. So.
Okay, fantastic. As Dr. Reddy mentioned, next we will have oral platform presentation session, which will feature the top 2 abstracts from our resident fellow category first, and then the top 2 abstracts from our student category. Each presentation will last 10 minutes of presentation time with 5 minutes for Q&A. And Sari will help me manage time and will give each presenter a 2-minute warning. And for audience members, if you'd like to pose a question during the Q&A, you can raise your hand using the reactions button at the bottom of your Zoom, or you can type your question into the chat if you don't feel comfortable speaking it. So next, first up, I believe we have Dr. Jakelski here, and I'll give you the floor.
Sounds good, thank you. So good afternoon, guys. Thanks so much for joining us. I'm Dr. Kahelski. I'm one of the 2nd-year pediatric emergency medicine and child abuse pediatric fellows over at Children's Mercy. And I'm so excited to be presenting our work today along with not only my good friend, but one of my co-fellows, who's also a 2nd-year Peds ER physician, Dr. Brian Stalker. The project we're going to be talking about today is improving the time to antibiotics in open fractures within our Children's Mercy Emergency Department. So next slide, please. So a little bit of an introduction. As we all know, kiddos get lots of fractures. They fall down, they break things, but one subset of fractures that's unique to kiddos that we want to take good care of are those open fractures, or where there's a break in the skin with an underlying fracture, because these open fractures pose an increased risk for infection. The American College of Surgeons, or the ACS, has published guidelines that anybody who works in a trauma type setting should be meeting when you're caring for children or adults with open fractures. So the ACS guidelines recommend that antibiotics should be initiated within 60 minutes of arrival to the emergency department, and this can reduce the risk for infection and can also reduce the risk for bone healing complications. So you can bring the next point in, please. So when we reviewed our practice at the Children's Mercy Emergency Department, we found that children with open fractures who arrived to our department less than 20% of the time met these ACS guidelines in having their open fracture get the correct antibiotic within 60 minutes. Next slide, please. So our SMART aim that we work towards with this project was to increase the percentage of patients with open fractures who presented to our emergency department that they would receive the correct antibiotic within 60 minutes of arrival, from the current 15% to 50% within 6 months, and further look to increase it to 80% within 12 months. We chose a process measure using the time from arrival to their antibiotic order. And for our balancing measure, to make sure we weren't getting other undue complications, we wanted to make sure and check the number of duplicate antibiotics that were ordered. So next slide, please. So our project timeline was between October 2020, and we're still ongoing with this project. And the setting we chose was our larger of our two emergency departments. So we chose the Children's Mercy Adele Hall campus, which sees roughly about 100,000 visits per year, with 94 open fracture visits within the last year. We assembled a multidisciplinary team consisting of different groups of physicians from the emergency department, our orthopedic department, our pediatric ICU staff, nursing staff from the areas, as well as engaging our transport team. You can see from the graphic on the right, this is our process diagram, kind of walking through what a typical patient may present with an open fracture to our ER. Obviously, the patient will arrive, get vitals, get triage, get room. The first opportunity for antibiotics to be ordered is when the first provider sees them. This could be a resident who would then need to go on and staff with either a fellow or an attending, or it could be one of our pediatricians that are working in the emergency department or one of our advanced practice RNs. If the child was seen by one of our advanced practice practitioners, antibiotics may be ordered right away as soon as it's identified. If the resident staff immediately is able to staff with an attending or fellow and it had identified an open fracture, again, this would be an opportunity for the antibiotics to be ordered. If it hadn't been identified by the first provider and a fellow attending goes and sees the patient and they recognize an open fracture, this then would be a second opportunity. As the child progresses through the ER, if it had not yet been identified, it may take an X-ray or the orthopedic team to come identify an open fracture, thus making 3 different unique opportunities where we could intervene. Next slide, please. So with our methods, in order to do a good root cause analysis, we utilized a fishbone diagram, which you can see on the left, to try and figure out where are some different areas that we might be able to target to really get our numbers up and help these kiddos get decreased risks of infections. Through using our fishbone diagram and using our root cause analysis, we chose to use a pick chart for our interventions on what should we implement in order to increase our numbers. You can bring the following bullets in, please. So using our root cause analysis and our pick diagram, we determined that education to providers would be a good area to target to start. So not only do we provide education on what an open fracture is, but also the ACS guidelines and reinforce the traumatic injury PowerPoint that we already had in Cerner, which I'll have on the next slide for you to look at. We also then chose to have our transport team engaged so they could deliver antibiotics to children who may be transferred in. So you can see here in this graphic, this is that traumatic injury power plan. The correct antibiotics using evidence-based research in the literature shows that cefazolin is the preferred antibiotic. However, if there is a cephalosporin or penicillin allergy, clindamycin is appropriate. So by educating providers on the ACS guidelines and reinforcing the use of our traumatic injury power plan, you can see the arrows point to the IV placement and again, the antibiotics. So you can pull in the next graphic, thank you. So for our education, these are the following dates in which education was completed within the various groups within our hospital. So the emergency physician providers, again, that consisted of the attendings, the fellows, the advanced practice RNs, and our board certified pediatricians, or our PAEMs, had education completed in November of 2020. The residents completed their training of this in February 2021, and this includes all rotators that would come through the Adele campus emergency department. Nursing completed their education in March 2021. The orthopedic providers, including their residents, was December of 2020, and the transport team started their engagement in education in March of 2020. And with that, I'm going to hand it over to Dr. Stocker to discuss our results.
Thank you, Dr. Kahelski. So as you can see with the results, looking at this, the administration of appropriate antibiotics within 60 minutes improved from 15% to over 50, or to over the 50% as the goal, which was a 56% total. Next point, our process measures, we did increase the median time from arrival to antibiotic order from 100 minutes to 49 minutes. And we did not identify any cases where duplicate antibiotics were administered. Some limitations. So our process is probably not very similar. It couldn't, possibly not be very similar to other processes. So possible lack of generalizability. And then there are fewer cases in the hospital due to COVID-19 in the pandemic. You're seeing, volumes low. So with that, we're seeing less open fractures with every visit that we have. So, that's going to be difficult to really kind of gauge how big of an effect our interventions had. Next slide. So in summary, with the education and given to residents as well as nurses, all the rotators, as well as working with transport, we were able to increase our number of patients number of patients with open fractures getting antibiotics within 60 minutes to less than 15% up to 56% in 5 months. And then we also improved our antibiotic time from 100 minutes to 49 minutes. Again, we utilized education to the ED as well as orthopedic providers, including residents and nursing staff. And then we engaged in the transport team to have them reach out to the referring hospitals to ensure that they gave antibiotics prior to arrival. In inclusion, we used the A3 problem solving and standard QI interventions, consisting heavily, again, on the provider education and the use of traumatic injury power plan to meet our goal of improving the administration and of appropriate antibiotics. Future directions, we would like to continue with our multidisciplinary team as well as with the transport team to continue the education moving forward in order to increase this even further. Follow-up rates of infections pre and post our interventions, we also plan to compare. We have no disclosures. We thank those people listed there and their assistance in helping us with this project, and there's the references below. And we would love to take any questions.
We'll give everybody one more minute. There's currently no questions in the chat box. We have one question from the audience about how difficult it was to create the EMR plan.
Yeah, so I'll let Brian, I know Brian had worked with, we actually have a physician who's not only a pediatric ER physician, but he's also works within our medical information technology. And he's a huge asset to have because he's able to help us create these power plans. We already had one, but Brian actually had gone in touch with him on how hard would it be to create a new one. So Brian, do you want to handle that?
Yeah, so assuming you have Cerner, it's really not that difficult. You just we have multiple traumatic power plans, and just getting with the right people to ensure that the antibiotics that you need are there, the X-rays are all there, making it really as easy as possible to get everything in one place was really quite easy, to be honest with you. Just like I said, you got to talk to the right people, and once you do that, they're able to put things in line to move forward with it.
I assume that involves various committees and stuff.
Yes. Mm-hmm. Yes.
We do have another question from Nick Clark. He says, great work, and was impressed with the team's approach to reach beyond the walls of Children's Mercy Hospital by involving outside hospitals in the care process. Have there been any discussions of standing orders for nurses to place an IV and start antibiotics based upon the nursing medication allergy history prior to physician seeing the patient, and if it's an obvious open fracture?
Quite a bit, actually. We did talk about this a lot, and there were some logistical reasons on why we decided not to do that. But with the education that we gave the residents, we did empower them. A lot of times with the process is the resident sees with the nurse at the same time now in our model, and then they come back and they staff. And so we empowered the residents to say, if you see an obvious open fracture, just order the antibiotics before you staff the patient. And that had quite a bit of intervention from what we could tell.
Yeah, there's definitely, as Dr. Sucker is saying, there's ongoing conversations within our last meeting, working with some of our charge nurses on, can we make a standing order? So it's in the works.
We have another question here from Dr. Paula Nichols. Very nice talk. What was the biggest challenge getting this project off the ground, and what roles did medical students engage in?
As far as the medical students, we actually just got medical students back. So I think they're going to become a larger part of the practice as we go. Unfortunately, through most of COVID, they were pulled from working with us in the ER. And a lot of our work during this was during the times of COVID and during those peak kind of fall times. So I definitely see them playing a role now as we get into summer and there's more fractures presenting, as they're going to be that initial provider in the room. So engaging them as we would our residents to empower them to identify it and come up with that plan. I think the biggest challenge to getting this off the ground was, I don't know, there was great buy-in. It was identified that we weren't meeting the ACS guideline, and everyone, obviously in medicine, we all want to do the right thing and we want to do it well. So once we had identified there was a deficit, it went through the charter and got approved so we could start working on this really fast. The education was really soaked up by everyone we talked to. I think one of the areas that's been one of the bigger challenges is the transport team, possibly, because you never want to step on an outside provider's toes. And they also, you can't have the people who are answering those calls within dispatch giving medical advice. So what's the right verbiage we should be using, and getting it to our transport team to have in the rigs to be able to give antibiotics. I think from my perspective, that would be it. Dr. Stocker, I don't know if you have anything else.
Yeah, just kind of echo what you said. I think the biggest challenge that we saw was a lot of the culture change, which is just, again, you don't staff the patient, order the antibiotics. They need to get the antibiotics within an hour. Just do what's best for the patient. And so, that was hard for some people to kind of wrap their brains around. But once we kind of got that moving, it stayed moving. And then what roles do medical students engage in? It's really just getting involved and recognizing that open fracture and having the wherewithal to come out and say, I need to order antibiotics, or if I cannot, you need to order antibiotics for me. But again, it's making that diagnosis, really using your physical diagnosis skills to see if there is an open fracture that needs to be treated quickly.
Okay, great. We'll do these next two questions and then we'll move to the next presentation. So from Dr. Julie Banderas, the initial flow chart looks very neat and streamlined. How difficult was it to gather the stakeholders and agree on the timing of the antibiotics?
Not very difficult at all, mainly because it's an ACS guideline. So the American College of Surgeons basically said, in order to properly treat these, it needs to be within 60 minutes. That kind of handcuffs you in a positive way, I guess you can say. So getting everyone to agree on the timing of the antibiotics was not the issue that we had, which was beneficial.
Okay. Great. And then from Nick Clark, as a balancing measure, were there any cases where patients received antibiotics who possibly didn't meet criteria?
I don't know if we've specifically looked at that. I know when we're doing our chart review, there have been patients who have received antibiotics where we don't see an open fracture diagnosis. So for the different fractures that we're including, obviously long bone fractures, but there is some controversy with skull fractures, distal finger fractures, like the tough fractures, if that's considered open. So cases like that where it's a little more controversial, if you do or don't give antibiotics, we chose to not analyze within at least our data set because of the controversy and kind of conflicting evidence out there. I'm trying to think though, I think most of the cases, if they had an open fracture, they got antibiotics. It just may not have met the ACS guidelines. So I don't remember any cases in which they didn't have an open fracture and still got antibiotics.
In addition, there are some trauma protocols that include antibiotics. So there were some cases where antibiotics were given for, say, a gunshot wound when they found out later no bone was involved. So I'm sure there, definitely were patients that received antibiotics that didn't meet the true open fracture criteria, at which point we discontinued after that. But yeah. So some did occur, but we did chart review kind of all the patients that had fractures and open fractures, whether they got it, but we didn't chart review all patients who got antibiotics.
It's a great point though for moving forward too, as we continue the sustainability with this as another balancing measure. That'll be great for us to bring back to our MDT. So thanks for bringing that up.
And thanks for your questions, everybody. They were very helpful for us.
Well, thank you guys for taking the time to present today, submitting that here. We appreciate it and strong work.
Thank you.
And we will move on to our next presentation now. Feel free to start when you're ready.
All right, thank you. Good afternoon, everyone. For those of you who don't know me, my name is Megan Hamner, and I'm the second-year Pediatric Infectious Diseases Fellow over at Children's Mercy. And I will also be talking about antibiotics, but in a different manner. So today, I'm happy to share with you all my quality improvement project entitled Improving Skin and Soft Tissue Infection Antibiotic Duration Concordance with National Guidelines in Pediatric Urgent Care Clinics. We can go to the next slide. So why is this project in antibiotic duration important? Well, there was a surveillance study of ambulatory prescribing practices across the country that was recently published that revealed that almost 40% of all pediatric antibiotic prescriptions exceed guideline recommended durations. And this matters because we know that prolonged antibiotic use increases the risk of adverse drug events and the development of resistant organisms, which are things that we really don't want to happen for our patients. And this is particularly important when considering skin and soft tissue infections because they are the second most common diagnosis leading to pediatric antibiotic prescriptions after all of the respiratory diagnoses. Next slide, please. And because skin and soft tissue infections are so common, there are treatment guidelines put out by the Infectious Diseases Society of America. And the current guidelines actually recommend only 5 to 7 days of oral antibiotics for common skin infections, including impetigo, erysipelas, cellulitis, and abscesses. And these are all things we see very frequently in pediatrics. And nationally, that surveillance data that I mentioned on the previous slide showed that 75 to 90% of pediatric patients end up receiving greater than 7 days of antibiotics for these skin infections, which is a pretty significant proportion. And so we were curious how our prescribing practices compared and found that in Children's Mercy urgent care clinics, only about 58% of patients were receiving the recommended 5 to 7 days of antibiotics per the IDSA guidelines. And so we aimed to increase the percentage of patients receiving that recommended 5 to 7 days of antibiotics for skin and soft tissue infections from 58% to 75% by December 31st of this year. Next slide. So in order to do this, we formed a multidisciplinary team, including urgent care physicians, advanced nursing providers and nurses, infectious diseases physicians, a data analyst, and a pharmacist. And we started meeting regularly that the best way of addressing kind of these prolonged antibiotic durations was to really understand and determine what factors, if any exist, would prompt an urgent care provider to prescribe a longer duration for a patient. And so in order to assess for these factors, we sent out an anonymous red cap survey to all urgent care providers. And this 22-question survey assessed various things, but importantly, it assessed provider comfort level with diagnosing and treating skin infections, assessed what their typical go-to antibiotic duration was for each of the common infections, what factors would prompt them to prescribe a longer duration, and we also assessed how comfortable they would be with prescribing a shorter 5-day antibiotic course for common infections. We had 27 out of 50 providers respond, and that gave us about a 54% response rate, which we were pretty happy with. And over here on the right, you can see a Pareto chart displaying the most commonly reported factors that do prompt providers to prescribe a longer antibiotic duration. There was quite a range. There were some that didn't even make it onto the graph, but these are the most common ones, with the presence of systemic symptoms being the one most reported. Next slide, please. In reviewing the remainder of the survey data, we found that the majority of providers typically prescribe between 7 to 10 days for most skin and soft tissue infections, which is longer than what is recommended in the IDSA guidelines. And so this kind of confirmed to us that there was room for improvement and that we had the potential to really improve things with this project. Next slide, please. And in reviewing specifically the provider comfort level with shorter durations, we did find that up to 26% of providers would be uncomfortable with providing a shorter duration for some infections, specifically abscesses and erysipelas, conditions that providers kind of considered a little bit deeper. And you can see those percentages here in the table. So once we had that survey information, we sat down as a group and performed a cause and effect analysis to identify additional root causes that contribute to longer antibiotic durations. And you can see this here on our fishbone diagram. Additional things that we really focused on was the urgent care environment in and of itself, because there's a lack of follow-up and a quick patient turnover, as well as technology, because the electronic medical record does have default prescription lengths in it. And so we thought that was an area for intervention. Next slide, please. So from there, we developed our measures and our data collection tools. So our outcome measure is the percentage of patients seen in urgent care clinics receiving 5 to 7 days of antibiotics for skin and soft tissue infections. And our process measure was looking at the number of updated prescriptions used from the skin and soft tissue infection prescription folder that is available for urgent care and emergency department providers to use. Our balancing measure was the number of patients returning with a skin and soft tissue infection within 14 days of the initial visit, because we wanted to ensure that our interventions were not increasing treatment failure rates. And in order to collect our data, we built an automatic monthly report, which pulled all urgent care encounters that were encoded with one of 50 different ICD-10 codes for these common infections. And we also gathered data on which antibiotic was used, the dose, the duration, and whether there was a return visit or not. Next slide, please. So once we had our cause and effect analysis, our measures, and our data collection tool established, we developed a driver diagram to identify the key drivers that would affect accomplishing our aim, as well as the interventions we felt would affect the key drivers, which you can see here. Next slide, please. And then we had a very engaged group, and so we had lots of additional interventions that we brainstormed, which you can see kind of listed here on the pick chart. And so we did place them on a pick chart to help us choose the interventions that we felt would provide the highest impact with the lowest effort. Next slide, please. And based on the pick chart, we felt that our first Plan, Do, Study, Act, or PDSA treatment recommendations at urgent care division meetings. This also gave us the opportunity to address any specific concerns provider had regarding shorter treatment courses and potential for treatment failure. And then our second PDSA cycle was to update the prescription order sentences in the electronic medical record for the antibiotics most commonly used for skin and soft tissue infections. We also then organized them to be displayed from shortest to longest duration, kind of to make it easier for providers to pick the shorter duration. And we also plan to update the skin and soft tissue infection prescription folder that I had previously mentioned. Next slide, please. So moving into our results, this is our annotated run chart. So as a reminder, our baseline before starting the project was 58%, and you can see that with the orange dashed line, and our goal was 75% up there at the gray dashed line. When our group formed in April 2020, shortly afterwards, we actually saw an increase in the percentage of patients receiving 5 to 7 days, up to 68%, although this was not sustained. And we believe that this was secondary kind of to word of mouth regarding the development of the project and increased awareness of the recommended antibiotic duration. The provider survey was sent out in July of 2020, and we again saw an increase in the percentage of patients receiving 5 to 7 days, although again, this was not sustained. And again, we also feel that the survey kind of prompted providers to think about, oh, maybe a shorter duration is okay. Next slide, please. Our educational updates for PDSA Cycle 1 were provided to one urgent care each month, with the first occurring in October of 2020 and the last occurring in December of 2020. And during this intervention, the percentage of patients receiving 5 to 7 days increased to our goal of 75%. The updated order sentences for PDSA number 2 went live in February of 2021, and we updated the 2 most common antibiotics prescribed, which is cefazolin and clindamycin, and we saw an increase in the percentage of patients receiving 5 to 7 days to 80%, and that has, as you can see, been sustained thus far. Next slide, please. So using QI methodology, we were able to increase the percentage of patients receiving 5 to 7 days of antibiotics for skin and soft tissue infections in our urgent cares from 58% to 80%. And most importantly, we did not see an increase in the number of patients returning with skin and soft tissue infections, which should be reassuring that shorter antibiotic durations do not increase treatment failure rates. Next slide, please. So in conclusion, prior to this project, like I said, only 58% of children were receiving the recommended antibiotic duration for skin and soft tissue infections. We were able to use QI methodology to attain our goal of 75%, and actually even greater than our goal to 80% of patients receiving the recommended antibiotic duration. We do have additional PDSA cycles, including providing direct provider feedback, the development of a treatment algorithm, and we have plans for sustained education. And our future goal is to hopefully expand this project into either the emergency department or the primary care clinics. And we also hope that our work with skin and soft tissue infections will allow us to expand antibiotic stewardship efforts to other common infectious diagnoses. Next slide, please. So these are my references. There are quite a few because I figured people would want to check them out. And I want to end by really thanking everyone involved in my project. There is no way it would have been as successful without their support. So thank you very much, and I am happy to answer any questions.
I have a question. If we could go back to the slide that shows the percentage increase, and yes, this one. And I had a question. The project started when?
So we officially started meeting as a group in April of 2020.
April 2020, that's what I thought. So there appeared to be an upward trend line for prescription patterns before that. Did you do any analysis to determine if there was a change in that trend line after the project was implemented?
Yeah, so we did absolutely notice that there was this upward trend even before we started the project. We actually have a time series analysis occurring right now. We're pulling the data for it to see exactly what the cause of this increase was, but we're suspicious that it's due to previous antibiotic stewardship interventions. There have been several that we have rolled out over the years, including the development of the outpatient antibiotic handbook, as well as we do cookie rounds to the urgent cares. And so we feel that those most likely caused this trend over time. But even with the trend over time, we only had 58% of patients receiving the recommended duration. So I think our project really helped kind of give the additional push.
Okay, great. There are a number of questions in the chat window, so I'm going to give you those in order.
Yeah.
So from Nick Clark, I really like that your team used a step wedge design and rollout of PDSA number 1. It will be interesting to see the results also presented with step wedge framework for urgent care. These approaches are utilized for a number of different reasons. Can you describe your team's decision to use this approach?
Yeah, so we decided to use this approach. It was kind of twofold. So we did actually initially think it would be best to address all the urgent cares kind of at once. But due to kind of all of the chaos of the pandemic, instead of having large every urgent care division meetings, they had kind of moved towards doing specific, like Blue Valley had their own urgent care division meeting, Northland had their own urgent care meeting, and it just became easier to attend one per month. And I think it was helpful because a lot of providers actually had really great input and questions that helped frame other portions of the project. And I think that might have been like that communication might have been lost if we had done it kind of all at once. So I think the stepwise approach really worked out well for us.
Great. And then from Dr. Jeff Hackman, great project and thanks for sharing your work. When you updated the prescription order sentences in the EMR, did you change to age-specific order sentences so prescribers are only presented with the options relevant to the child they're seeing, or perhaps maybe it was already set that way?
So great question. We did not change the age specifically, but we did have it filtered kind of by weight. So the different options like liquid and like tablets, we had those. We kind of, I wish I actually had it to show you how we kind of organized it. But we had it filter by patient weight and by max dosing from shortest to longest duration. We did not address age in that.
Great. Yeah, and he should have said weight instead of age. That makes more sense.
Oh, yes, we did do it by weight.
And just a comment about really the soft nudges with the human factors approach about resetting the default orders to a lesser or shorter duration. So that was a comment. Yeah,
we felt that would be really helpful because we in the urgent cares are very, very busy, and so we felt that anything that made it easier would be appreciated and probably would give us pretty good bang for our buck.
Fantastic. Any other questions from the audience before we move on to our student presentations? All right, great. Thank you so much for your presentation and for your work. All right, so now we're going to move on to the student abstract presentations, and these are listed in no particular order. And so same for the audience, these students will have 10 minutes to present and 5 minutes for questions. And as long as our student presenter is ready, we will go ahead and get started.
Hi, my name is Malika Joshi. I'm a third year in the BA/MD program at the UMKC School of Medicine. And today I'll be presenting Improving the Sleep Quality of UMKC Medical Students, a Quality Improvement Project. Get the next slide, please. So burnout is a pervasive problem within the medical community, and it's often the culmination of neglected self-care, stress, and overworking. It can lead to a decreased quality of life for physicians and poor healthcare outcomes for patients. Can I get the next slide, please? We began our investigation into our peer sleep quality by gathering a team of UMKC medical students and faculty advisors via the Quality Improvement and Patient Safety workshop offered as part of the CPM1 coursework. We then formulated an initial survey that we sent to all medical students in order to determine how many hours students slept per night. We received 104 responses, which reflected an average of 6.99 hours of sleep per night. We did have a suspicion that although people were sleeping on par with the recommended hours per night, their quality of sleep overall was poor. We then followed up with those respondents in another survey to confirm our suspicions and better understand sleep quality. We decided to measure sleep quality using a 5-point Likert scale that we created, where we set 1 to signify waking up groggy and hitting snooze, as well as 5 to being energized and ready to start the day. Get the next slide. From the second survey, we learned that the average sleep score of UMKC medical students was initially surveyed as a 2.68 on a 5-point Likert scale. Thus, the aim of this quality improvement project is to increase UMKC medical students' sleep score from 2.68 to 3.68 over a 6-month period. Can I get the next slide? So we began by creating a fishbone diagram to identify potential causes to the scores that students had reported. Potential causes broadly fell into 6 categories: schoolwork, electronics usage, mental health, substance abuse, social obligations, and environmental factors, all which cumulatively negatively impacted sleep quality. We identified these particular stressors based on self-reported hindrances to restful sleep, which was obtained from the initial survey that we had sent. Can I get the next slide, please? Based on the fishbone diagram, we then utilized a PIC diagram. Thank you. We utilized a PIC diagram to identify the highest impact potential interventions. PIC diagrams are used to categorize potential interventions according to difficulty and impact, and we wanted to choose 2 that would be easy to implement with our classmates and would yield the greatest increase in sleep scores. We chose establishing routine sleep schedules in the form of a daily sleep calendar and reducing blue light exposure before bed as the 2 interventions we would then sequentially implement over a 6-month period. We chose to use routine sleep calendars as we felt it was an important aspect of maintaining our work-life balance. As students, we tend to hyper-organize our study habits already, so why not extend these same practices to our sleep hygiene? We offered multiple ways in which for students to do this, such as logging when they went to bed at night and woke up every morning, or simply trying to sleep and wake up at the same times every day. Additionally, we chose to target blue light exposure specifically because of the amount of time we spent using our electronics daily. Given the impact of the COVID-19 pandemic has had on how we administer classes, exams, and overall studying, attempting to mitigate blue light exposure can have long-lasting positive effects. We instructed students that they can utilize the night mode function on their devices, wear blue light glasses, or put away electronics altogether 30 minutes before bed. Next slide, please. As students implemented each intervention, we would ask them to re-report their sleep scores via bi-weekly surveys. This represents our outcome measure. We maintain student participation in the surveys by conducting raffles for $5 gift cards for every bi-weekly period, as well as a larger $40 prize for students who participated in every single survey over the course of the 6 months. Our process measure is reported intervention adherence, in which we ask students how many days per week they avidly practice the interventions. Students were given the option to report compliance every weekday, most of the weekdays, some of the weekdays, few of the weekdays, and none of the weekdays. Furthermore, we also asked students to report any negative consequences that they felt that these interventions had to function as a balancing measure. Some students reported sacrificing time dedicated to social events and studies, while some other students stated that no matter what measures they took, their sleep quality did not improve. Next slide, please. Our initial survey, which had 104 responses, and we are displaying pertinent survey findings on this run chart. With the implementation of daily sleep calendars, students reported sleep scores that increased from 2.68 to 3.60 from January 21st to February 18th. After introducing the decreased blue light exposure measures, we observed a slight decline in sleep scores from 3.60 to 3.34 from February 18th to March 4th. Regarding data not presented on the run chart, 46.8% of students reported sleep calendar adherence, while only 19.3% reported blue light exposure compliance. When asked if they experienced any negative consequences to these interventions, 6.7% of students reported feeling as though they sacrificed their school or social life. Next slide, please. UMKC medical students demonstrated an average 0.92 point increase in their sleep scores after implementing a sleep calendar. These scores briefly declined with the addition of a second intervention. However, we recognize that this particular survey period occurred during midterm exams, which may have impacted how students chose to report their scores. Our QI efforts are ongoing, and with continued implementations of the interventions, we hope to sustain the improvement that we saw. We also acknowledge a limitation in the sleep scores and the other data that we received, as they were all received by surveys, which presents a bias in which students, as well as how many students were actively completing the surveys. For each one, we had a minimum of 30 participants, which did maintain our sample size. And we also recognize that sleep scores could potentially be skewed due to underreporting of those sleep scores by participants who were not actively implementing the interventions. Next slide, please. To conclude, overall, both intervention methods that we utilize proved effective in improving sleep quality. This topic will continue to be of importance as medical students develop in their careers as physicians. Tackling the issue of sleep deprivation and improper sleep hygiene early on will only serve to improve physician health and enable us to provide better patient care. Thus, our study advocates for more exploration into sleep quality, as well as increased investment in the support of student self-care. Next slide, please. We would like to extend a gracious thank you to our mentors, Dr. Alfagali and Dr. Harris from Children's Mercy Hospital, for their continued support and guidance with our project, as well as for partial funding of our participant incentives. We would also like to thank the UMKC School of Medicine for their support in educating us on quality improvement and providing us with this opportunity for presentation. Thank you, and I am open for questions.
All right, we have a question in the chat box from Nick Clark. Great work, team. It's wonderful seeing medical students involved in QI safety work. Sleep fatigue and sleep deprivation are ubiquitous problems in healthcare. If you were to continue the sleep work, what would be your next steps and future directions?
Yeah, so we are planning, like I said, to stop this project after 6 months, and we were only able to implement 2 of the interventions. But I think my next steps would be to attempt to implement the other interventions that we had displayed on the pic chart. For example, reducing caffeine usage late at night, trying to make our nighttime environment as conducive to our sleep hygiene as possible. And if it were to happen, continuing the survey beyond the 6 months to cover those potential interventions, I think is a great way to continue to monitor the sleep hygiene practices of our classmates.
Great, thank you. From Dr. Paula Nichols, very nice project. For those students that actively engage in this healthy sleep program, did they report an improvement in mental health or concentration?
Students were not asked in our surveys about their mental health and concentration. However, that is something that is incredibly important for us to focus on as well. And I will suggest to my teammates if we could broaden our survey and include more survey questions to ask how students feel regarding their academic performance.
Great, and then a comment from Stacy Farr. And provider burnout is now the 4th aim of the IHI triple, now quadruple aim. So great focus on this domain. And then Dr. Betty Dries, it's innovative to use a QI approach to wellness. Are you planning to submit your work for publication?
We are currently working towards submitting this for the IHI submission deadline. I think that's in a couple of weeks.
Great. Another question, what implications do you think the outcomes of your work has on the medical school and its curriculum schedules?
I think some of our findings are very reflective of how students are given their time to use for themselves in their academic and personal lives in relationship to how the school is administering their classes. So for example, in my year, I'm a 3rd year, I know that our classes run from 3 p.m. to 6:30 p.m. generally. And we have clinic throughout the day as well as workshops. And I know that this leaves very little time for us to study as well as focus on other wellness measures. So I think that seeing just how poor sleep quality can get is a testament to how students have to practice or work on balancing their own sleep with the standards set by the school.
Great, thank you. Have you thought about ways to include a control group so that the variation in exam time could be accounted for?
We did not consider a control group because we kept the surveys open to everyone from across all 6 years. And we were unsure about how to go about doing that, considering every single year has different schedules and not everybody is taking synchronous classes past year 3.
Okay, great. We have a good comment here from Stacy Farr. Use of wearable sleep trackers could be a great future step for you to include more reliable and rich data on sleep. And then a question about from Dr. Paula Nichols, were you able to assess if there were any male-female differences?
We weren't able to assess if there were any female and male differences directly. However, I was noticing some trends in the survey compliance. Most of our respondents were from females, and if male students were to respond, they were the ones who were leaving comments about their concentration, their thoughts about the implementation process.
Okay, great, thank you. And just to tag on to that, Dr. Jeff Hackman said it would be interesting in the future to look at educational outcomes, like test performance, particularly in light of your comments about the timing of the interventions related to it.
And I think that's an interesting topic as well, and perhaps we can add that onto our surveys. I would wonder if students would be willing to disclose test scores or other information about their academic performance, but I think that is something that's definitely worth looking into.
You had a lot of questions. That's a good thing. Anybody else? Okay, fantastic. Well, thank you for your time and all of your work.
Thank you.
Congratulations and good luck. All right. And next up, you're ready to go whenever you are.
All right. Hi, everyone. My name is Kayla Rifle, and I'm a medical student here at UMKC. Our project today is improving breast cancer-related lymphedema detection, creating a standard practice for preoperative arm measurements. So I want to begin today by giving you some background information on breast cancer-related lymphedema. This is a type of lymphedema that occurs after lymph node surgery or radiation due to the lymphatic damage and destruction. It's characterized by marked arm swelling and heaviness, and it develops in approximately 20% of female breast cancer surgery patients. So a crucial step in proper diagnosis, management, and improved outcomes is obtaining baseline arm measurements prior to surgery. So while the National Accreditation Program for Breast Centers lets each program determine the best way to implement lymphedema detection in their practice, the National Lymphedema Network recommends that every patient receiving lymph node surgery should have these preoperative arm measurements. And studies show that 40 to 50% of patients without preoperative arm measurements who develop lymphedema are misdiagnosed. So it's crucial to have this kind of surveillance in a lymphedema surveillance program. And then when we examined the patients at Truman Medical Center and University Health in 2019, we discovered only 38% of axillary lymph node dissection patients and 30% of sentinel lymph node biopsy patients, or combined 35%, receive these important baseline measurements. So before we explore the quality improvement measures, I want to take a minute and explain how we obtained the 2019 data. So we obtained a list of breast cancer patients receiving lymph node surgery in 2019 from the cancer registrar. It included 58 patients total, 13 of which received axillary lymph node dissections and 45 received sentinel lymph node biopsies. So then we performed a detailed chart review of all 13 axillary patients and 10 randomly selected sentinel lymph node biopsy patients to determine our 2019 rate of preoperative arm measurements. We did exclude 2020 data due to disruptions from the COVID-19 pandemic. So now I'd like to explain a little bit about how we determined the root cause of the low percentage of patients receiving these measurements at our institution. The Truman Medical Center University Health Breast Program Leadership Committee performed a root cause analysis using a fishbone diagram as seen here. Just to provide some context, previously patients would receive a referral to occupational therapy for these measurements, but it was noted that they had a difficult time keeping their appointments. So in July of 2018, an advanced practice nurse was trained to do arm measurements in the clinic. But implementing this was spotty as seen by our low percentage rate. So we identified the root cause this far in the program's development as a lack of standard practice. So we sought to improve this percentage by designing a standard practice that has two parts. The first part includes identifying eligible patients by a breast nurse navigator. And then the second part, as you can see on the bottom of the diagram, is taking the arm measurements at the initial appointment with the breast surgeon, and that's done by an advanced practice nurse. So our hope is with both of these things to improve our rate of preoperative arm measurements. And our specific aim of this project is to double the rate of baseline arm measurements in breast cancer patients undergoing lymph node surgery to greater than 70% by February of 2022. And while our data collection is ongoing, we did look at all of the patients who had nodal surgery or plan to have nodal surgery since implementation, which is about 2 months of data. This includes obtaining a list of patients from the cancer registrar and performing a detailed chart review like we did before. Our methods this time though were slightly different than our pre-implementation collection methods, just because we counted every eligible patient this time, whereas previously we chose a random sample of patients. So we then performed a chi-square test to compare the differences in rate in 2019 versus 2021. Okay, so this chart compares the rate of preoperative arm measurements pre-implementation on the left and post-implementation so far in 2021. So as you can see, in 2019, 8 out of 23 patients, or 35%, received preoperative arm measurements. And so far in the 2 months of data that we have, 6 out of 6, or 100% of patients have received these arm measurements. So to summarize the results, analysis of our available data suggests that adoption of the standard practice has significantly increased the preoperative arm measurement rate at Truman Medical Center and University Health. And while the results thus far are promising, the data are limited due to our small sample size because of this new implementation. So our future plans include continuing to analyze the data until February 2022 and meeting again with the Breast Program Leadership Committee to discuss challenges that they noted or unintended consequences as seen by the clinical staff. So our hopes with this is to provide a useful model that offers excellent care to our specific patient population and hopefully will be of use to other safety net breast cancer centers. And I'd like to thank Dr. Amadea for her knowledge and support of this project. And I would also like to thank the staff at the Breast Health Clinic for obtaining the patient data for us and implementing this new standard of practice. Now I'm open to any questions.
Great. Well, we're waiting for questions to come in. Can you comment on what made you think about this project idea?
So I had reached out to Dr. Amadea for any potential research project, and she had noted that this had been something that needed improvement within the breast program here at Truman Medical Center. So it seemed like a reasonable thing to try to improve on.
All right. From Nick Clark, great work. Love that your team was working to target misdiagnosis / overdiagnosis. It may be early, but has there been a change or reduction in the rate of post-op lymphedema now that patients are getting pre-op measurements?
Yeah, so I'm not sure yet. I think it is a little too early to tell, but that is definitely something that we will look into later on in the project towards the end of it.
And I'm curious if you guys, with this next phase, are looking at ways to recruit more participants for your study, or are looking at ways to increase the number of enrollment eligible patients?
I think you cut out a little bit for me. Do you mind repeating that? Sorry.
Are you guys looking at any ways to increase the number of patients you capture in your study?
Not currently, just because it's very specific to patients that are receiving any breast cancer patient that's receiving lymph node surgery. So it just depends on what kind of patients are seen in the clinic and if they end up needing axillary lymph node dissection or a sentinel lymph node biopsy. So it's kind of specific to those two patients.
And then another question from Dr. Reddy. Very high caliber work. What specialty do you plan to pursue?
I actually don't know yet. I am interested in surgery and in breast health, thanks to Dr. Amadea, but I really don't know until I start doing my rotations.
Okay, fantastic. Well, thank you very much for your presentation and your hard work.
Thank you.
I just wanted to make a comment as Dr. Medea. I wanted to thank everyone at the medical school for the curricular changes that we heard about earlier, because Kayla Rifle she brought the fishbone diagram to our breast program leadership committee meeting. She really brought a lot of that knowledge with her as a student and contributed to this project. So I want to thank everyone on the medical school side for really educating the students in that way and allowing us to have such a fruitful partnership.
Great, thank you for that comment. And thank you for your mentorship. And thank you to all the presenters, and Dr. Badadri says, I'm very impressed by the quality of our work and our learners, both residents, fellow students, and thank you to all the faculty mentors. So that concludes our poster session.
Outstanding work, everyone. I think if it's okay with everyone, we can just continue, even though we're just a little ahead of schedule, and maybe we'll take a longer break before the advisory committee meeting, if that works. Right. Yeah. Outstanding set of platform presentations. Thank you, Emily, for your moderation, and thank you to all the presenters and the individual contributors, mentors, faculty, judges, for making that session possible. All right, so we're going to move into a poster recognition and award ceremony, and we'd like to review the highlights of the annual QIPS poster showcase. I'd like to recognize the top abstracts and honorable mentions in each category, which has not yet been revealed to you. I'd like to recognize faculty members and staff who support this improvement work, and we'll close with some comments and reflections from the Rayudu family. So in another time long ago, we would have been presenting the scholarly work of our learner community in the hallways of the 4th and 5th floors of our medical school building. But despite the challenges of these times, we still want to provide an opportunity to showcase the hard work and outstanding output of our students, residents, and fellows and faculty mentors who've rallied to overcome in these unusual circumstances. So in lieu of presenting and printing life-size posters to stand next to while reviewers and judges strolled by their posters, we asked each team to record an audio narration of their poster presentation and submit it with a slide of their poster. These videos will be posted on the Quality and Safety Day website that you can review at your leisure following this program. So as I reviewed these presentations earlier this week, I was overjoyed to make several observations that I'd like to share with you. As you review the outstanding poster showcase, you'll see projects focused on surfacing gaps in health disparities. I commend the work of surfacing gaps in COVID-19 preventive knowledge among Sojourner Health Clinic patients. They used volunteers as a control group. A study of the impact of social determinants of health on diabetic foot exams and on COVID-19 disparities, gaps in homeless individuals seeking corrective eyewear, and the impact of poverty and COVID-19 infection rates, and comparisons of rural versus reoperation rates of stress urinary incontinence. You'll see the important topic of improving communication, highlighting work and showing variations in the perceived value of timeout huddles, understanding the impact of personal protective equipment on speech attenuation during the pandemic, the influence of internet access and usage on trends in online diabetes education, integration of an atherosclerotic cardiovascular disease risk calculator into the electronic medical record, implementation of an end-of-shift electronic nursing summary, and efforts to improve communication to improve and ensure appropriate telemetry use. And then a topic that's very dear to me is burnout, resilience, and well-being across healthcare worker disciplines. You'll see the attempts to reduce resident burnout through mindfulness meditation, the role of cognitive mapping in surgical resilience, and an assessment of barriers to medical student participation in local elections. You'll see projects about improving sleep hygiene for medical students, which we also heard during the platform presentations. And one project looked at safety in the workplace by monitoring safety in the ED through improving security at the entrance. And finally, a project comparing medical student stress levels before and during the pandemic. In addition to studying communication and social determinants of health during the pandemic, you'll see a number of efforts to study the current pandemic climate because it's timely. You'll see an attempt to discontinue contact precautions for MRSA patients to conserve PPE during the pandemic, projects exploring vitamin D levels during the pandemic, variations in high quality mask usage, an effort to improve continuity of care by converting no-shows to telemedicine. What would healthcare be during a pandemic without technology? And finally, a case report of Cauda-Equina syndrome in a patient who was initially scheduled for a telehealth visit. You'll see several projects that used knowledge assessments and implemented educational interventions to assess variations in mask ventilation knowledge and skills among experienced and novice providers, a simulation and hands-on education training for ultrasound skills to assess acute cholecystitis, an effort to improve knowledge and confidence in focused bedside echocardiography, standardization of resident education in the pediatric GI clinic, and a simulation-based curriculum to improve central line competency. We must always keep visibility to harm caused by a medical treatment, diagnostic procedure, or healthcare worker. So you'll hear about the iatrogenic harms assessed in the evaluation of medical devices and risk factors for medical device recalls. You'll hear about a method to track the force used during retropubic trocar passage. While oxygen is generally a healthy resource, it can also cause harm, as one study explored the appropriate initiation of oxygen. You'll hear about experiments to study the risk of thermal burn in cataract surgery, studies about radiation exposure, and an assessment of vancomycin toxicity. The work of improvement science focuses on relentlessly surfacing the gaps. You'll see strategies to reduce surgical site infections, projects assessing gaps in tobacco use cessation counseling, rates of newly diagnosed children registered at state and regional mental health offices. You'll see a retrospective evaluation of medical errors using a fishbone diagram, a review of trends in sunscreen use among adolescents, variations in missed appointments in patients who had another appointment scheduled in close proximity, and rates of comprehensive foot exams in patients with diabetes. Now let's talk about the valuable work of improvement projects when it comes to improving outcomes. By closing known gaps based on established best practices, you'll see the impactful work of projects that improve utilization rates among families of organ donors, improve compliance with Turner syndrome guidelines, improve vaccination rates in high-risk populations, a 5-step checklist to lower opioid prescribing, and efforts to increase documentation of pain prevention measures. And finally, you heard earlier from our platform presenters, efforts to improve compliance with guidelines for antibiotic duration in pediatric urgent care centers to improve time to antibiotics in open fractures presenting to a pediatric emergency department, and use of a preoperative arm measurement standard to improve breast cancer-related lymphedema detection. You'll also see in the poster showcase use of swipe sense technology to provide regular compliance reports to improve hand hygiene and improving the timing of intravitreal eye injections to optimize pain management. We hope that you can take time to review the poster showcase that features the results of the hard work and dedication of these learners and their faculty mentors represented across the consortium. Now I'm going to hand off to Sari to show us how you can access the poster presentation recordings online.
All right. Hi, everybody. My name is Sari Cantrell. I am just going to quickly explain how to view this year's virtual poster showcase. So as you see on the screen there, I'll add the link to the chat, but it's also very easy to find just by Googling the Vijay Babu Rayudu Quality and Patient Safety page. That takes you to our event page where you can find links to each narrated poster in the showcase. And there are over 50 posters in this year's showcase submitted by students, residents, and fellows. And there's also an option if you prefer to sit back and relax and watch the entire showcase, you can do so by clicking the link at the bottom, which is the 2021 video playlist. There it is. All right. And after today's live event concludes, we hope you will visit the virtual poster showcase and share the link with your friends and colleagues. And I do want to say thank you to Christopher Boyce. He worked with me to get all of these videos uploaded. Again, over 50 videos. So it was a lot of technical work in the, behind the scenes to get this set up for everybody. And then a great big thank you to the participants themselves who all took the time to create these posters and record their narration for you. So please check it out. I'll put the link in the chat for you.
All right. Thank you, Sari, and thank you so much for all your support and work and hours of effort that have gone into creating this platform for us to be able to feature this showcase. All right, so you had the opportunity to hear platform presentations from the top 2 abstracts in each category, but I also wanted to take a minute to be able to tell you also about several posters in both categories that received honorable mention. While these projects were not selected for platform presentation, they are worthy of honorable mention based on the really high scores they got by our judges. So here are the student honorable mentions, and here are the resident and fellow honorable mentions. And this just highlights the level of work that's gone into what we might consider a competition, but all of these posters have required so much work to even be able to put together the abstract, submit, create a poster and a video narration to go with it. But the quality of the quality work is so impressive, and it just gets better every year. And to each of you who presented orally or by a poster with an audio narration, you can claim credit for your work by citing this abstract using the following format. And here's a format you can use. And note that generally speaking, the first and second authors listed contributed the heaviest lifting to the project's completion, along with other team members listed chronologically in between. And the last author listed is generally the mentor or advisor of the project. So you can reference this format in the recording of this event that'll be posted on the website next week, or quickly take a screenshot of this image. I'd also like to take a moment to thank the record number of 37 judges who helped us in this process throughout the last month or so. And without this kind of participation, this program would not be possible. So thank you to all of our judges. And I want to thank two important people for their hard work, tireless contributions to making today's event possible. Mary Eberwein has provided administrative support for the activities of the QIPS Consortium since its initial launch in 2014. Sari Cantrell is a newer addition just over a year ago and serves as a technical and operational genius of the day-to-day operation of the consortium. And it is with a bittersweet sentiment that I announce to you that our beloved Mary will be retiring at the end of this month. The consortium would not be what it is today without Mary's tireless dedication, attention, and care. And I, for one, already miss you, Mary. And I also want to thank Tracy Rogers for valiantly representing St. Luke's in the consortium's work over this past year that's been so challenging. And I wish you the best of luck in your next chapter. With deep respect and gratitude, I'd now like to ask Dr. Dries, the founding leader of the consortium. Dr. Dries is one of my highest role models and of course a valued mentor and a driving force behind this program's success. And Dr. Dries will be presenting the inaugural QIPS Faculty Mentor Award of the Year. Dr. Dries.
Dr. Dries, you are on mute.
Oh, so sorry. Thank you, Dr. Reddy, for allowing me to do this presentation. You know, watching this this Quality and Patient Safety Day over the years grow and expand, it's been very rewarding, and it's the result of hard work from a lot of people over the years. But it's really rewarding to see that we can start formally recognizing some of the people who mentor and have such contributions to the students, residents, and fellows developing their QI projects. So this year, our inaugural Faculty Mentor of the Year award goes to someone who's been involved since the very beginning and has helped mentor scholarly experiences in the internal medicine residency program, has championed structured improvement methodology as a curriculum, and provided mentorship to students, residents, and other faculty. And one of his really tremendous contributions was taking our fledgling abstract presentation process and bringing a lot of improvements to that. And so not only mentors the learners, but also mentors his colleagues and has made this abstract competition much more robust. And so I'd like to recognize Dr. David Wooldridge as the inaugural QIPS Faculty Mentor of the Year. And since we're not in person, we have a picture of the plaque that will be getting Wooldridge in the next week or so. I don't know if Dr. Wooldridge suspected that he was going to get this and if he has any words to say. But again, thank you, Dr. Wooldridge.
He did not suspect this.
Then we did a good job of keeping it a secret.
Yeah, hang on just a second. The irony is, you know, like so many folks of my vintage, I didn't get any, you know, quality improvement, patient safety training when I trained. It just didn't exist. So I feel like not the mentor, but I've had the opportunity to learn more about this than anybody else, you know, probably over the last decade or so. So it's been what an amazing opportunity to be part of this and surrounded by all of the quality leaders that we've had across the institutions. And thank you very much. Really appreciate this and look forward to continuing to be a part of this for years to come.
Well done. Well done. And just a couple of reflections that I have. This whole process has taken many years and a lot of people involved. And two things that I remember from the time that I was dean. One, of course, was the Rayudu family after Vijay's death coming and asking how they could do something that contributed to improving medicine that ultimately led to establishing an endowed chair and on into this program. And the other thing was Dr. Larry Dahl, when he was considering leaving private practice and coming back as a docent, and he said, Betty, we need to do something to train our students and to get them involved in quality improvement projects. And so he has just been a tremendous partner in this through the years. And then seeing Dr. Reddy as our second endowed chair, and Dr. Hillman now chairing the steering committee, and all of the people who participate as mentors or in the projects. It's just been extremely rewarding to see this. And this day in particular, because when we were looking at how to make an impact, we wanted to make it scholarly. And it's so important to see that these projects that our students, residents, and fellows work on result in something scholarly, that they have an abstract at a regional meeting that they can put on their CVs that really shows that they didn't just say they're working on a project, they did something that led to an abstract, and a lot of publications now are coming out of this. So I feel really blessed to have been part of all of this. And with that, I would like to now introduce the Rayudu family, who I believe are all on. And do we have a photo? Sorry. Here they are. This is the Rayudu family who have been the driving force behind making this happen. And again, looking at ways that we could honor Vijay's memory and make that lasting contribution to medicine. All of his family members are physicians. His parents, Rao and Subalakshmi Rayudu, who are now retired. His sister, Haru, is a graduate of the School of Medicine as an ophthalmologist, and his brother, Ranga, who is an internist in California. And this is one of the family photos. Oh, I think they're continuing to add members of the family. I believe there's another baby since we were last together. So welcome to all of them, and thank you for, again, being the driving force behind something that I think is a really good way to honor Vijay's memory. And with that, I'll turn it over to, I believe Ranga has a few words, Dr. Ranga Rayudu, on behalf of the family.
Hi, thank you, Dr. Dries. Good afternoon, everybody. Yeah, we're very happy to welcome the newest member of our family, Sita, just about a month old. So on behalf of our family, we want to extend our sincere, heartfelt gratitude to all the students, faculty that submitted all 57 projects. Looked like great projects, great focuses of quality improvement. And we really appreciate all the students, residents, and faculty judges. We also appreciate all the work over the years that has gone into growing the program. And a large part of that has been thanks to Miss Mary Eberwine. We're very sorry to hear that she will be retiring and leaving us, but we're grateful to have had her as long as we have. Congratulations, Dr. Wooldridge. Well-deserved recognition. He has mentored 3 generations that I've seen so far of medical students on the path through quality improvement. And as Dr. Myers mentioned in her presentation, the future of the QI in the academic curriculum depends on positive experiences. And we really appreciate all of the positive experiences that all the faculty have contributed to the students and through these projects that have made such an impact. I believe UMKC has some of the most inspiring academic clinicians out there. So thank you again to everybody, faculty, Dr. Wooldridge, Sari Cantrell, Dr. Dries, Dr. Reddy, and thank you for carrying this program forward. Thank you. Back to you, Dr. Dries.
Thank you very much. I'm very optimistic we'll be in person next year, so we'll love to actually see you in person next year.
I hope so.
And before I turn it back over to Dr. Reddy, I just want to also recognize that we couldn't continue to do this work at this level without the support of Dean Jackson, who has just been a tremendous supporter of what we're trying to put in place here. And with that, I'll turn it back over to Dr. Reddy.
All right. Thank you, Dr. Dries. Thank you, Dr. Rayudu, for your comments and for the family's support. I think we're ready to close this program. I had just a couple of closing comments. I see this quote, "Great things are achieved by a series of small things that come together by an artist." And I think of this work that we do, and as Dr. Myers articulated, all the work is so important. It's not just about the care we directly provide to patients and through the system, but how we work every day to improve that system in which we care. And how that work is done is the work of everyone every day, all the time, thinking about the gaps and seeking ways to fill them in our own small ways, maybe not always in a formal effort of a project, but it is these incremental changes, these what may seem like a small project at the time, these are all additive and iterative, and that's how we create the better system that we all seek to live in and provide care in. So thank you to everyone who has been a part of the program in terms of behind the scenes and working on projects that may not have even been reflected in the author line, but so many people are doing this great work every day, and I commend you all. Want to make a pitch for next year's annual event. Here's a save the date for Friday, May 13th. We always seek to make this be the second Friday of the month for consistency, unless there's, a pandemic that changes our plans and we need more time. So please mark your calendars for Friday, May 13th of next year. And special thanks to our moderator, oral presenters, abstract judges, all the learners who submitted abstracts, and thank you again to the Rayudu family for your support of this important work.